Hello everyone, this is Dr. Donna Schminke, and I'm going to be with you throughout this course as we learn what's what with women. Whether we think of this as women's medicine or female reproductive health care, this is going to be a journey in which you learn how to take comprehensive health care of women who will be your patients as primary care providers, and perhaps some of you will be in specialist settings as well. Let's get started. To begin with, I want to speak briefly with you about what it means to provide care to well women throughout their lifespan. To do this, we need to look beyond the traditional boundaries of biomedicine and do our best to consider more than parts, but rather the whole of a woman's experience. She's not just an acute problem to be solved, but a whole person who experiences the changes of development or aging and acute or chronic problems in social contexts and with specific cognitive abilities and various skills that define her as an individual. I encourage you to try to develop relationships with your patients so that you have some grasp of their personhood. It will go a long way towards developing good rapport with your patients, and it also helps you provide the best care possible given an individual's life situation. Each one of us has a unique history of challenges, traumas, anxieties, successes, and hopes. Please try to always explore and honor that in both your patient and in the staff who work alongside you. If you are feeling rusty about your gynecologic anatomy and physiology, I want to refer you to the chapter 6 in our textbook because it is just what you need. I'm not going to spend a lot of time going over detailed A&P in this module. The objectives for this lecture are mainly these three listed below, which are also found on the course content outline. Explaining the 8 current priority areas for well women care, which is really the framework that we're going to use in this lecture. We will also be discussing cervical cancer screening in some detail, and I want you to be able to describe the components of well woman care by age group. And to that end, there are links at the very end of this, or the second to the last slide on this lecture, and also the same links in recommended readings for this lecture on the content outline. Our priorities are shifting in women's health, and it used to be that people talked about needing to go for an annual wellness visit, to their annual pap smear visit. And the good news is that once a pap smear, not always a pap smear, women don't need to have annual pap smears for the most part anymore, but that message has been a hard message to sell to patients. So there are a lot of people out there who still come in thinking they should get a pap smear, and there's a lot of confusion around what it means that that's not the recommendation anymore. So we need to educate our patients that this does not mean they're getting less care, they're getting better care. I have so many patients who think that this lack of an annual pap smear is about insurance companies not wanting to pay for a cancer screening that people really need. So you need to spend some time teaching them that there are other reasons to come in for an annual wellness visit, and that actually we do have coverage for this thanks to the Patient Protection and Affordable Care Act of 2010, the ACA, that covers these annual well woman visits, but that actually having us scrape cells off their cervix to see if they have cervical cancer, if we do that every year, it actually leads to invasive procedures being done on people who don't need them, and that their outcomes, the chance of them being hurt or dying from cervical cancer is not affected by this change in annual pap smears. And we're going to talk more about that in some slides ahead. When we talk about the 8 priority areas for well woman care, we're talking about these 8 priorities, and we're going to walk through these for the rest of this PowerPoint. That's really the structure we're going to use. I'm not going to read through these here. You can read through them yourself. The first of the 8 priorities is reproductive life planning and sexual health. This is what most of us think about when we think about what happens in an OB/GYN office setting. But the truth is that in most OB/GYN clinical settings, they provide well-rounded primary care service for the women that they care for. It is a great thing that we have the ACA mandate now that I mentioned in the last slide. It means that women have access to this care, and that's a good thing. We are going to cover the specifics of this mandate of priority 1 in the second week of this course when we talk about sexual health across the lifespan and normal and abnormal female sexual functioning. And then we will cover, I believe it's in week 3 that we cover contraceptive services and infertility. We will also get to sexually transmitted infections in week 4, I believe, or maybe week 5. I'm not real clear on that as I'm recording this. So hang in there for all of that material. For many decades, the routine annual GYN services were all centered around an annual pap smear for cervical cancer screening and a bimanual exam for pelvic pathology. And this has been turned on its head in recent years. Back in 2014, the American College of Physicians actually said you don't need to have routine screening pelvic exams anymore. And then in 2018, the American College of Obstetricians and Gynecologists, ACOG, issued a committee opinion basically saying that pelvic exams need to be used when they're indicated by someone's medical history or symptoms. And I'd also say that they're including risk factors in there. If you've got somebody who has had multiple sexual partners since they were last seen, or their partner, or a new partner, or a partner who they suspect has had other partners, that person needs STD, STI screening. So, keep that in mind, that medical history includes risk factors. Based on the current data, though, we really can't say that a woman needs a bimanual exam to find pelvic pathology. That is an outdated, or at least it's a notion that has been put on hold until we have better data. And so it's the decision to do a pelvic exam, if there's not a compelling reason in the history or symptoms, is a decision that you make between you in discussion with your patient. And different women will have different answers for that. And a lot of it does have to do with their level of comfort. So currently, we do recommend low-risk women have Pap Nicolau screening every 3 to 5 years and bimanual exams as indicated. Just to note that in regard to this priority area, 1 in 5 sexually active women are not using any form of contraception, and 1 in 2 pregnancies in the U.S. are unintended. So please always ask about reproductive intentions and try to determine what somebody's risk is of having an unplanned pregnancy based on the kind of contraception they're using and who their sexual partners are, and take the opportunity to talk to them about their contraceptive methods, about the warnings that they need to notify us about if they experience any untoward issues, and what they need to do if they notice that they have not had a perfect use of that. If they're not using a long-acting reversible method or a long-acting permanent method of birth control. These are issues that are very real and could help prevent an unwanted pregnancy to have that discussion. So take advantage of the opportunity. Cardiovascular disease and stroke are our number 2 priority for our women's health visits. And although the specifics of this are truly beyond the purview of this course, there are a couple of things I want to point out. Number one, when you're taking a history, you should always inquire about whether women had any preeclampsia or gestational diabetes, abbreviated here as GDM, which these are conditions we will cover in detail under pregnancy complications, but you should know that these 2 conditions increase a woman's risk for cardiovascular disease, for heart attack and stroke. And so it's important that you know if she has experienced those in the past. Also, I want to encourage you to deal with her modifiable risk factors, especially regarding weight loss and smoking cessation. These are things that simply telling a woman she should lose weight or stop smoking will never work. You need to develop a relationship and encourage and help her find strategies that can help accomplish these goals. Here are some links to some resources that can give you strategies to help women accomplish those goals. The third priority for these patients is prevention, screening, and early detection of cancers. And particularly, we're looking at doing pap smear and human papillomavirus testing and vaccination too with HPV, screening for breast cancer, screening for colon cancer, and promoting smoking cessation to reduce risk of these cancers. We won't be talking about colon cancer screening beyond this lecture in this course, so here are our screening guidelines, and I'm happy to answer questions as best as I can about this during our lecture, but I think it's pretty self-explanatory. The fourth priority area is unintended injury, and this is definitely outside the purview of this course, but simple things like talking to people about gun safety, seat belt laws, seat belt safety, helmet safety, those are things that, those should be the kinds of things that are just second nature to you as you're providing primary care to patients, right? Screening for depression, anxiety, substance misuse, and suicidal ideation is priority area number 5 for a women's health visit. And of course, you all know that this is a pervasive issue in our culture right now. Even before we reached these recent years, I would find that sometimes 80% of my patients that I'd see for primary care visits in my office, I was finding that they were depressed or anxious. So this is a very pervasive thing, and it's also, again, beyond the purview of our course. But I urge you to please screen women for these issues at every visit. Assessing for assault, intimate partner violence, and homicide risk is also a critical part of our role as primary care providers for women, and thus it is priority area number 6. We'll be touching on this with intimate partner violence at some point during this course because that is one of my areas of expertise. So look forward to that. Lower respiratory disease, definitely not my area of expertise, but we do want to be addressing these things with patients. So keep this in mind as you're taking care of men and women. Arthritis and musculoskeletal issues are this is an area that we need to be screening for, particularly screening for the problems is you're taking care of aging populations, but in a younger population, you need to be teaching them about preventive strategies so that they don't get injured, evaluating how active they are and how safe their activity is. Before we wrap up this lecture, I want to recall for you two of the objectives for this module. First, to understand well-woman recommendations across the lifespan, I want you to take a look at this 2021 ACOG well-woman recommendations chart that I've linked here in purple. Then, I strongly urge you to make a chart similar to this for yourself. Don't just copy it and stick it in a notebook somewhere, but work with it. It may be helpful to make columns for the different age groups, such as ACOG did, and then categorize your rows according to the 8 priorities of care that I've just been discussing. This way, you can actually conquer 2 objectives for this module at once. I didn't present these priorities in the order that I've listed on this slide because of Pascal's 2016 scoping review. I presented them in the order that they were presented there. But I find it helpful to recall the 8 areas by thinking cardiacs. Maybe you will find that useful too. So I encourage you to think about organizing your chart that way. Congratulations, you made it through the first lecture in this course, and I want to encourage you to write your questions down, either post them on the Ask the Professor discussion board or come to my office hours to talk about them, or write them down and we can talk about them on Wednesday in class at 9 a.m. I'm looking forward to meeting you then. Take care, everybody. Bye-bye.